Hi, I'm Daniel Butler. I'm a board certified dermatologist. I work at the University of Arizona, where I am the vice chair of education, and I lead a research program called the Inflammatory and Aging Skin Research Program. And we look at how aging is a risk factor for many of our inflammatory skin diseases. And we try to unpack all the levels of that. Yeah, we teach our students and our residents about shared decision making from day one. And what shared decision making really is number one, trying to understand what the patient's goal is. Is it to get rid of all the lesions on their skin? Is it to get rid of the itch? Is it to get rid of the joint pain? Or is it that they don't like the flaking in their scalp? All the other things doesn't bother them. It's really understanding the patient and then the other side of shared decision making is making sure the patient understands where we are coming from and our decision making processes. Now, if we're using the example of psoriasis, we really have a menu of options. And so it really isn't that we just come in with our ideas and we just, tell them exactly the direction that they're going. And so I think part of the shared decision making is also helping people understand what I affectionately call the menu of treatments or the menu of options and letting them choose, but making sure that we are communicating that menu. And we can use it in psoriasis, you can use it in other inflammatory skin diseases, but this also applies to treatment of skin cancer, which is a really tough thing in older adult patients, where the menu has things like Mohs micrographic surgery or excisions or electrodesiccation and curettage, or even active surveillance, where we do nothing and just watch an active basal cell or squamous cell in the right situations. I saw a great lecture by a geriatrician about the five M's of geriatric care while I was at Elevate. It was a wonderful lecture, and it really emphasized these sort of checkpoints that we should all have with older adults. Things like mobility, what matters most, medications, mentation, and multi-complexity. Those are the five. But those are check boxes for us. Not that we have to use them on every patient, but we can always sort of use those checkpoints to make sure that the decisions that we're making and the conversations we're having are focused on those really five key points of geriatric care. So those are things that I'm going to take home with me. I think there's a really cool trend that we are getting much closer to being able to understand and treat the symptom of itch or pruritus in a way that we never have before. We still don't have any FDA-approved medications for itch, which is one of, if not the most common symptom that people come to a dermatologist for over the age of 50. And so this trend of us understanding what causes itch in many different situations and being able to target it is really exciting for us as clinicians because we finally have something that we can use for this ubiquitous population who's really suffered. And then it's also really exciting for patients because finally they're going to get some relief. And we're seeing this convergence of therapeutics, patient concerns, basic science all come together in this fun soup where we're able to finally address this major issue, and it's all reaching a boiling point right now in a good way. So that's the trend that I'm most excited about. That we are looking at deprescribing as a part of the practice in dermatology. Deprescribing is where you take either unnecessary or redundant medications off somebody's plate. And it's not that we want to take medications away or make people more miserable. It's actually the opposite. We're trying to take medications, or we should be thinking about our ability in dermatology of taking redundant medications away. And why this comes up so much in our practice is that people often will see other people for dermatologic conditions before they end up coming to us. So for example, someone has hives or they have some other itchy condition, and all of a sudden they come to us on several antihistamines and prednisone, and no air of that provider who provided those, but now it's on us to not only bring in more targeted therapies, but also make sure that we're reducing the risk for that patient by deprescribing some of those other medications. So we should be really, really active in that area. And we're starting to find that dermatologists certainly do contribute to deprescribe or to polypharmacy, which is too many prescriptions, but we have in our skill set the ability to take some of those low-hanging fruits away and simplify our approach. So that's going to be a fun new topic for us to bring into the clinical realm.